Buckle up. All right, so Tuesday, October 27th, we're going to go through the rest of the central nervous system, discuss a couple of key features with the brain. Last time we were together, we went through the spinal cord, so we're just going to continue with the central nervous system and finish off with the brain. We do break it up into 6 divisions. The first 3 divisions, the medulla oblongata, we just usually refer to it as the medulla when we're talking about or discussing the brain. Pons and midbrain. So those first 3, medulla, pons, and midbrain, we're in essence working our way. We just left the spinal cord, so now we're actually past that foramen magnum and are inside of the cranial cavity. At that point, the spinal cord basically becomes the medulla oblongata. And then the medulla kind of becomes the pons, and the pons becomes the midbrain. In essence, we're working from inferior to superior. Okay, medulla is the most inferior aspect of the brain, and then pons, and then midbrain going superiorly. Now, we can clump these first 3 together as into something we call the brain stem. So I'm sure many of you have heard that, or if you've started doing any of your work with this particular unit, you maybe run across the term brainstem. And when we see brainstem, we're actually referring to these 3 items. It's kind of like a flower, right? The spinal cord is, I guess, maybe more like the stem of the flower, but as you get up to the brain, the actual flower, the brain stem kind of connects the big aspect of the brain with the spinal cord. Okay, so anyway, first 3 are brain stem. And then we get into what we call the cerebellum. That's a little kind of extra brain in the posterior area that we'll look at here in a few minutes. And then the diencephalon, we've heard of a couple of the items within the diencephalon. I know that's kind of a mouthful of a word, but we have seen thalamus and hypothalamus. So we would consider those when we discuss the diencephalon. And then lastly, the main portion of the brain, I think the aspect of the brain that most of you probably have heard of, or at least seen, especially it's Halloween time, right? Brains. So that's the cerebrum, the biggest aspect. The cerebrum size relative to the rest of the brain for humans is unlike any other animal. It's really what separates us from most other animals in the animal kingdom is our cerebral size relative to the rest of our brains and how much we're able to use as well. But anyway, brain development starts pretty early on. We see when fertilization takes place, we have a zygote for the first maybe week to 10 days at the most, and that zygote is working its way out of the fallopian tube en route to becoming an embryo, and then as it finally works its way to implanting itself into the uterine wall. Well, during that zygotic stage into being an embryo, we're already starting to see the beginnings of a nervous system. So once we're at about 2 weeks after fertilization, so between like basically week 2 and week 8 after fertilization, so the first trimester, easily we're going to see what's called a neural tube and a neural crest and what they call neural folds. So we see the beginnings of a spinal cord and brain and an entire nervous system. So that happens really early on. Billions, hundreds of billions of neurons and glial cells. We're making synapses, which are connections. Those are made and broken certainly throughout our lives. And but again, as we discussed last time, if the cell body of a neuron is damaged enough, then the neuron is done. It won't do anything. But if the rest of the neuron is damaged, we certainly can repair that. Prenatal development, again, very early on in the embryonic stage. Now, let's move into the first section of the brain stem. What we see in this kind of mid-sagittal section here, this kind of side view, again, we can see this bright yellow portion indicating the brain stem, which again is the medulla, the pons, and the midbrain. Now, the pons kind of means pouch. So you can see there's a little bit of a pouch. It almost even looks like a backwards P. So if you were, if we were in class, you guys would be dissecting sheep brains, and you would have to identify both on human brain models as well as the sheep brain. You would have to identify these parts of the brain stem. So again, the pons is pretty evident with that kind of big pouchy area. Okay. So anyhow, we do see a posterior view. We see the medulla, the pons, and then a little tiny chunk of the midbrain. The midbrain's not really that large. The pons and the medulla make up the bulk of the brain stem. It is more maybe kind of a oblique side posterior view, lateral posterior view. We also see coming off the medulla and the pons, these little kind of, I don't know, extenders coming off of here, these little arms. These are going to be nerves. So we're going to look at cranial nerves. They're cut, but these would continue going on through, probably contained within the cranial cavity. Most of the cranial nerves are going to stay within the cranial cavity. We do see a couple that got snipped right here. Those are your optic nerves. Those will go to those feed your eyeballs, and the visual aspects come in. But anyway, a lot of your cranial nerves come off of the brainstem. Okay. And there are a couple, we're not going to spend a heck of a lot of time going through the specific regions or areas of the brainstem. I just mentions pyramid and olive. Again, not real concerned about that for now. I think it's important for you guys to really grasp that as the spinal cord enters into the cranial cavity, the first stop is going to be the medulla, and then the second stop is the pons, and then the midbrain. And collectively, that is called the brain stem. I think that if we kind of stick with that, we're going to be good. Now, while we're on this slides, it does have this diencephalon highlighted in purple as well. And the diencephalon is going to be the thalamus, the hypothalamus, which we can see over here. And then also the pineal gland is going to be included in that as well. We see this term optic chiasm. Optic chiasm, again, that's going to be, you can see the optic nerves have been trimmed here. This forms a little bit of an X. What we're going to see when we do vision and cranial nerves is that the left eye nerve comes over to the right side of the brain. Okay, and the right eye nerve comes over to the left side of the brain. So they do form a chiasm. That just means like an X, basically. A chi is an X in Greek alphabet. Okay, so the optic chiasm or chiasma. That's where the optic nerves come in. Okay. And then we have, again, the hypothalamus is going to be right beneath or inferior to the thalamus, there's also a little item right here. It's been cut and it's not really part of the brain itself. It's more part of the endocrine system. But do you remember we looked at the pituitary gland connected to that hypothalamus? So as that hypothalamus kind of comes down to a point here, we would have the pituitary gland kind of sitting right here. And remember that pituitary from last Tuesday, we learned is the master endocrine gland. So there's a lot of connection and a very, I guess, strategically located spot for that pituitary gland, because we see, remember that the pituitary kind of triggers us to go out of homeostasis when we and into a sympathetic or stress mode. And so our visuals are one of the main, I guess, kind of relayers or sensory mechanisms for bringing in potential dangerous situations that our body needs to respond to. So this cascade effect of hormones is going to get triggered, certainly from sound, from visions, from smells, etc. But anyway, as visuals are coming into the brain, they're ultimately going to head toward the occipital region of the brain. But as they pass through here, we're already able to start making some connections that, all right, let's get this cascade of sympathetic hormones released to start that fight or flight mechanism. So anyway, this area of the brain, again, is considered to be very primordial, very primitive. So when we think of the functional aspects of this whole area, so diencephalon and brainstem, that probably, again, the areas of the brain that most of us don't really think about or consider when it comes to brain discussions. But these are the key aspects of maintaining the most basic elements of homeostasis. So when we think about blood pressure, when we think about respiratory rate, when we think about heart rate, when we think about the most basic elements, internal body temperature, right, with the hypothalamus, the thalamus, what you're looking at on this slide is really kind of the bread and butter of the most basics of homeostatic mechanisms. So this also happens to be kind of our relay station remember the elevators last week. We looked at the spinal tracts. So as sensory is coming up or is ascending through that ascending tract, okay, so we're bringing sensory up before the sensory ever even gets to the top of the brain or the cerebrum, where we start processing what sensory just came in. Before it ever gets up there, the sensory is going to pass through the brainstem and the diencephalon. So this is also kind of like a relay station area. In fact, it's part of what we'll see in a little bit. It's part of what we call the reticular activating system. So we're going to, again, this is your relay station. We've got sensory ascending elevators coming up. We've got descending motor elevators leaving and heading back down into the spinal cord. And so again, all these roads and pathways, and this is basically like a hub of activity. We're going to see some of these sensories are going to get directed over to the cerebellum. Some of these sensory are going to get directed into different areas of the cerebrum, whether it's, the more temporal zones or occipital zones. Okay. So keep that in mind too, that again, not only is this thalamus, hypothalamus, pineal, and then the brainstem, the kind of the deepest, most protected area of the brain, it's also the most primitive, most basics of homeostasis are going on here. So anyway, we'll keep moving again. Medulla, the lowest part of the most inferior aspect of the brain and of the brain stem. It's what attaches to the spinal cord. And again, we're not too concerned about pyramids, olive, and nuclei at this point. That's a little more advanced anatomical discussion. And then the pons was just superior to the medulla and inferior to the midbrain, kind of that central P-shaped or pouch area. Pons means pouch. Okay, and then the midbrain heading finally up more internally within the brain. We're going to see that connection to the diencephalon. So this is kind of the midbrain. Is just that. It's the midsection of the brain. And again, what are the functions of the brain stem? Again, collectively, this is where we see sensory, motor, reflex, all kind of converging from the spinal thalamic tracts. Those are those ascending tracts. Remember, when you're asked as if it's an ascending or descending tract, we're simply looking at the beginning of the word or the end of the word for our clue. We're looking for the word spinal or spino. Okay, if spino is at the beginning, then this is going to be an ascending tract. What it means is that the sensory is beginning in the spine and spinal cord and heading up to for this one to the thalamus. So this would be an ascending or a sensory tract. And then we come down here and we have spino-reticular. So again, spino at the beginning. So these are all sensory tracts. And then we come down to the bottom one and we see spinal is at the end of the word. So this tells us that this is a descending tract. This is a motor tract. The end of the word has spinal. That means that's where, in essence, the line ends or where the elevator stops. Okay, so the elevator stops at the spinal. That means this is a descending tract that's going to be bringing motor. So again, my point is the midbrain, the brainstem, the brainstem, the medulla pons, midbrain. This is a hotbed. This is a relay station where all these tracks, all these ascending spino tracts are coming in with sensory signals, and then where we see these descending motor elevators going down and delivering the response. So stimulus comes in, response goes out. Okay, so let's see. Reflex, some of the key features, again, reflex centers are going to be in the medulla. Within the pons, we're going to see the pneumotaxic centers. So that may seem like a crazy word, but it does have a couple of items in it you maybe are already aware of. You've all heard of pneumonia at some point, so you know, and therefore you probably know that pneumonia is something with the respiratory system, right? With the lungs or the chest and with breathing. So pneumo, and then taxic has the word taxi in it. So just like a taxi, well, nowadays it's Uber and Lyft, right? But the pneumo Uber centers, these are delivering sensory signals. They're delivering the respiration rate signal. Okay, so pneumotaxic, delivering respiratory signals. Okay, so that's contained within the pons. And again, we saw several cranial nerves coming off of really the entire brain stem. So we'll talk about the specifics of cranial nerves here in a little while. Cerebellum is the second largest part of the brain. The cerebellum, we'll see, there we go. It's this big kind of blob of cauliflower, again, toward the posterior aspect and the inferior aspect of the cerebrum and of the brainstem. So it's kind of nestled back here again in the posterior aspect. We're still contained within the cranial cavity. So it doesn't show it, but you could almost see the skull. So this would be the occipital bone here, kind of coming around, and then the foramen magnum right in this area. So we're still contained certainly within the cranial cavity. Okay, so there's the cerebellum. You can see there, and again, it's going to have, we'll see it coming up, that reticular activating system, or that relay station is going to involve the cerebellum. The cerebellum, so let me come over to this one. This is actual tissue. So anyway, some of these ascending tracts that enter into the brainstem, some of them may kind of shift over to the cerebellum, and then some motor responses may come out of the cerebellum. So cerebellum does a lot with some of our basic motor control, some of our muscle coordination. So when patients are coming in and you know, they've got, they may mention, or their spouses. A lot of times it's the spouse that'll, oh, he's been running into doorknobs or bumping into the coffee table, or he's been falling a little bit more. We're worried about, his balance and stuff. Well, you could have inner ear issues, right? We could have where a lot of our balance is, but motor coordination, is kind of centered in that cerebellum. So we could have some sort of we could have something going on. We could have a mass or something that's affecting some of the cells of the cerebellum. Therefore, they're affecting motor coordination or muscle coordination and control. Okay, so that's cerebellum. It has, when we dissect it, it has kind of a tree look to it. So you do see this term, arbor vitae. Those are bushes, right? I think my neighbor's got some arbor vitae. Those are those kind of green, kind of pyramidal shrubs that you guys will see. That means tree of life. Right? Arbor means tree, and vitae has to do with life. So the arbor vitae, whenever you see that term in anatomy, it relates to the cerebellum. It relates to the appearance of the cerebellum. Okay, so the arbor vitae of the cerebellum. All right, so we'll see more with cerebellum as we go. There it is, arbor vitae. It's going to be white matter. Again, as we leave, remember, spinal cord is white matter surrounding gray matter, right? So white matter is on the outside with spinal cord, but as we go into the brain, we get a switch. So now white matter is going to be on the inside, gray matter on the outside. And remember, white matter is going to be more the myelinated aspect. That's where we would see axons, dendrites, whereas the gray matter is more nucleated. That's where we would see the nuclei of the neurons. So anyway, the arbor vitae, internal white matter. Structure, we're not going to get too much into that. Functions of the cerebellum. So again, just know arbor vitae for structural aspects, and know that it is in the posterior and inferior aspect of the cranial cavity. Again, we're thinking about motor skills, motor control, some of the most basic aspects too of what we call proprioception. Proprioception is again your body's kind of awareness of where of where you are in space. Are you upright? Are you horizontal? Are you angled? Are you side to side? Are you looking left, looking right? That's proprioception. So when a patient has lost proprioception, or their ability to understand where they are in space, we could have some sort of cerebellum issue. And again, fine skilled motor movements are going to be cerebellum. Maintaining balance, your regular balance, maintaining posture. Okay. We do see certainly a lot of sensory, a lot of the ascending tracts are going to go into that cerebellum, because again, the sensory, when the body senses that it's falling, so I sense that I'm moving this way, that signal is coming up to the cerebellum, telling it that you're moving this way. And so the cerebellum sending a motor response to bring you back to center, or to at least enable you to not fall completely onto the ground. So again, Cerebellum is big with motor control, muscle coordination, posture. Okay. So this is that reticular activating system pathway that I mentioned a little bit ago. Again, we can see in blue we have, in essence, the ascending sensory signals coming in. So we see that as we enter into the brain and into the cranial cavity, we see that the ascending pathways. And remember, sensory comes in the back and motor goes out the front. So we see again, usually sensory tracts are going to be more posterior or dorsal. Hey, well, they make pit stop right away at the cerebellum. This is again the first response of am I in motor control? Because remember, this is all about the brain deciding whether or not we need to flee or fight, or if everything is hunky-dory. So first stop is going to be muscle control, motor coordination. Do we have that in line before we get up and assessing the situation in the cerebrum? Okay, so cerebellum receives a lot of that sensory information, and then typically it's going to pass it on. We have a little nucleus in there called the dentate nucleus. So again, that's kind of the relay button within the cerebellum where that sensory comes in, and then it we can decide where we're going next. Are we going to go directly to the brainstem, back into the midbrain area? Are we going to send that signal all the way up into the diencephalon and ultimately into the cerebrum? Is this something that we need to remember? Is it that type of sensory input or information? Sometimes, again, we just need a quick response. So we do see that again, as that sensory leaves the cerebellum, sometimes it'll just go right to the brain stem, and then notice we can start that descending pathway to get a motor response. So we don't even involve the cerebrum. This again would be some of the basics for perception of awareness in space. So this is constantly going on. This relay station, ascending, descending, sensory in, motor out. Okay. And again, if that sensory is really something, if you touch something really hot, really sharp, you're going to get an immediate response all the way down in the spinal cord. We don't immediately involve the brain and the thought patterns, right? Remember that simple reflex arc. We touch something hot, sensory goes to the spinal cord, motor goes out the spinal cord. Well, in the meantime, though, we are getting some ascending information that's going to eventually come up here and nestle itself right into your memory bank. So this big area, the cerebrum, is where we're going to store memory. So next time I see a thumbtack or a hot plate or hot stove or whatever, a burner, I'm going to keep my fingers away from it. Okay, so that memory gets etched in. Notice before it ever gets up here to the memory aspect, this is also your analytical aspects way up here, the mental and analytical aspects. In this central area, on our way to getting into the cerebrum, we do find what we call the limbic system. So we'll see that coming up in just a second. But I did want to mention this is your emotional, kind of the seed of your emotions. Whatever those, anger, jealousy, rage, bliss, joy, inside out, right? This is where that lives. Okay. Inside out is your limbic system. Okay. So as all these sensories are coming in, there's going to be some emotion potentially involved as well. Okay. Let's see what. Oh, and again, the diencephalon, this area of the thalamus, hypothalamus, they control the sympathetic aspects, the blood pressure going up, heart rate going up. So again, if depending on the degree of intensity of pain or of stimulus that's leading to the nociceptors picking up that pain. If we travel into this area, then again that pain gets your heart racing, gets you sweating, gets you kind of maybe even feeling a little bit woozy. You may have a blood pressure drop all of a sudden. You may go into shock, right? Depending on the degree of pain. That's going to be right here in this diencephalon. Okay, so as sense, depending on the degree of intensity of that sensory, as it passes through, it's going to trigger that fight or flight stuff. And whereas down here, if we don't need to trigger any type of response and memory, we just have to go right over here to the brainstem. So that what I'm saying is this ascending, all sensory. It's not just a matter of am I touching something hot or cold? Am I feeling fuzzy or warm or what? It's way beyond that. You're getting information sent, especially to this area, just constantly while you're asleep, while you're awake. There's just this constant flow of information sensory wise coming up, and it all relates to proprioception. It's just your body's communicating with the outside world. Am I falling? Am I standing? Am I sitting? Are my muscles toned? Are they flopping to the ground? Because we always want to keep some sense of tone to the body. We want to, and so that's all unconscious. The brain isn't thinking about this. We would never get anything done, right? If we were constantly worrying about whether we're like falling or not, or whether our muscles are toned enough or not. So that's what this constant little station here is. When we go beyond that, when we go into, okay, now I'm cooking, or now I'm driving, or now I'm out in the yard doing work, now I'm handling things, whatever that is. Now we're actually involving like more than just am I falling, am I standing, am I leaning, am I looking right, am I looking left. We're still doing all of that, but we're also now starting to include the emotional area. We're also starting to include the thinking and the memory area. Okay, so it's not like one stops and one begins. It's all going on forever and hopefully not forever. Well, I don't know, maybe, who knows. But anyway, it's going on for a very long time. Hey, I hope all that, I think that makes sense. Your brain is very active, but the area of the brain that is most active all of the time is going to be right in here. Okay. This is, again, your primitive area. While you're sleeping, things are happening here. Now, do we have dreams and memories? Sometimes dreams are emotional, even. You wake up and you don't remember them. What area of the brain? So somehow it is activated in the cerebrum, right? Sometimes we fall asleep and we wake up and we don't, it was just black, right? There's nothing going on. Other times we go to sleep and the whole night, it's like we're more busy while we sleep than we were during the day, traveling and talking to people and interacting and being busy. So that's still going to all be up in this area. So there's something going on with the chemistry of probably the pineal gland is where a lot of the research goes when we talk about dreaming and wake and sleep states and consciousness. Remember, the pineal is that melatonin producer and releaser. Melatonin levels melatonin responds when there's no sun out. So when you're asleep and it's dark, that's when melatonin is busy. So anyway, part of that is replenishing and fixing all of the damage that was done and allowing some of the cells to rest and repair. Other aspects certainly are going to relate to the dream state. So anyway, that's for another class. That'd be your psychology stuff probably. Yeah. which if you take psychology, you'll certainly study some of the basics of brain anatomy and stimulus response stuff. All right, well, while we're here, this is again the thalamus, the thalamic area, and then we see the hypothalamus and the pituitary. Okay, so this is that diencephalon. So we started off with the brain stem, right? We did the medulla, and then the pons, or this pouch, and then the midbrain. Then we did the cerebellum, because again, you can see that is all connected, that brain stem with the cerebellum. This is your basic relay station. This is where we decide again, or the brain decides whether to perpetuate the sensory or the stimulus all the way up, or to just continue with its normal pattern of cycling through proprioceptive mechanisms. Okay, so we left the brain stem, and this is that diencephalon. We saw the pineal gland nestled back here, the thalamus into the hypothalamus. And we see the pituitary coming off of the hypothalamus. Okay, so that's kind of where we're at now. We do see this white area here. We'll look at that in a few minutes. That's called the corpus callosum. This is going to connect the two hemispheres of the cerebrum. So our next stop is going to be with the cerebrum. Okay, so we're going to head into the cerebrum next and talk about kind of the uppermost kind of your thought areas, your memory, your analytical aspects. I skipped through a bunch of slides, what they discuss. Let me go back to a couple of them. A few of them we're not concerned about. This gets into, the first one gets into a lot of details of specific anatomy. I don't want you to go that far. I just need you to know that the diencephalon is the thalamus, hypothalamus primarily. We'd see the pineal gland also in that area. Again, this is the diencephalon is that kind of relay station. The next, it's another relay station. This time we're looking more or less at, again, like emotional aspects, what we call the limbic system. We see the continuation of, again, primordial aspects of blood pressure, body temperature also being regulated in this area. Okay, so again, how the anatomist kind of, again, we think of the brain as being your physical aspects of your body, the emotional aspects of who you are, and the mental aspects. And so they tell us that based on this reticular activating system and structurally, that this region of the brainstem and cerebellum, this is your most basic physical aspects. This regulates your physicalness, your muscle tone, your muscle movements, regulates your ability to breathe, your heart rate, just some of the most basic, what makes us physical is all located here. In the brainstem and cerebellum. Now, as we travel into the diencephalon, the thalamus, hypothalamus, we're still dealing with some of those physical aspects, certainly, but we're getting more into maybe a deeper aspect of the emotional levels. This is also the seat of sexuality, the seat of sexual behavior is also in that diencephalon area, the thalamus, corpus callosum, hypothalamic areas. So, and then, so this is again, the emotional brain is what they call it, this region here. Okay. And then lastly, the what they call the mental brain or the analytical brain is the cerebrum. That's everything else. So this is where thought patterns, where memory is stored. Okay. Okay. And again, all roads have the potential to lead up to the, so notice again, we travel through the most basic of the physicalness of who we are, and then the emotional aspects, and then the mental thought, analytical aspects, and then the responses travel back through those areas. So when you talk in psychology about behavior being learned, and we talk in medicine about PTSD and some of the physical manifestations that come from emotional traumas that were experienced and stored in the memory banks, you can see this link and how connected everything is. How something in here can manifest and travel and hold itself somewhere in your guts, or somewhere in your kidneys, or somewhere in your lower back, or your elbow, or your shoulder, or your hips. So all these nerves that are leaving the spinal cord, we'll see shortly, are going to travel and end up somewhere to produce motor responses. All the nerves coming into the spinal cord are bringing, or to the brain, are bringing sensory information. So anything that has occurred in an individual's life has the potential to have a memory, and to have an emotion attached to it, and to have physical attached to all of that. And that stress, what we see in the clinic, the hypertension levels, the metabolic issues, the digestive issues, and so on and so on. All of these clinical everything clinical that we see seems to have some root within the central nervous system. So pain, one of the first things that we ask is to rate your pain on a pain scale. Again, it's very subjective. It's for that individual at that individual moment in time. So that same individual at a different moment in time is going to perceive a different level of pain depending on what type of treatment they've received, and possibly just depending on their thought patterns. So anyway, there you can see how the nervous system is bringing in, and if we do have chronic inflammation somewhere in the body, or maybe everywhere in the body, that information of sensory is being brought continually to the spinal cord, or from the spinal cord up to the brain, into the cerebellum, and finally landing itself potentially up into the memory banks. Before it gets there, it's going through that emotional level. If any of you have had experience with it, or whether you yourselves or patients, chronic pain can be extremely emotional, detrimental to the emotions. It can lead to thought patterns that are unhealthy. So again, we know pain is subjective, but we also know that every individual's perception of pain is relevant, and it's up to us to figure out a way to treat it. And the last 20 years or so, the treatment, or more even, treatment for pain has come in the form of a lot of heavy opiates and opioids, a lot of narcotics, level pain medication. And so it's led to a lot of issues. It's not treating the physical manifestations that have led to the perception of pain. Again, physical pain. So someone that's come in for pain medication because they're in pain, we have to be very careful, very cautious with how we approach it. So especially now more than ever, the opioid and opiate epidemic is beyond the pale at this point. It has been for a while. And so when we assess it, we again are trying to get an understanding then of how pain works, and what the mechanisms are for where they travel and where they can manifest, and how they can certainly affect the emotional state of the individual, and the behavior and thought pattern aspects of that individual. So keep that in mind as you go. Next semester, we get into some physiological principles of the nervous system, of how some of these drugs work, how they affect different neurotransmitters that we're producing, and how they sometimes just aren't there, and so we need extra help. So anyway. That's what that's the complexity of the pathways of all of these sensory and motor that are coming in and out of the central nervous system. Okay, so again, the thalamic area, that's your arousal mechanisms, your emotional mechanisms are located within there. Again, hypothalamus is that link between the mind and the body. It's that connection with the pituitary gland, which then distributes its stimulating hormones to other glands of the body. So again, a lot of the motor response pathways are going to involve that thalamus, hypothalamus, pituitary, and then the release of those hormones to affect other glands and hormones in the body. And again, typically related to like a fight or flight kind of response or a sympathetic response. So again, hypothalamus is going to coordinate a lot of those automatic activities, what we call autonomic nervous system, which we haven't made it there yet. We will see the autonomic nervous system shortly. All right, so let's see, pineal we've already discussed. So let's look at the cerebral cortex. Let's get up into the mental aspects, the analytical aspects. We do see that it's divided into right and left hemispheres. So we have a left brain and a right brain. Okay, left brain and right brain. That corpus callosum that I mentioned, that kind of white area that we'll see here coming up. There it is. This white area here, this is the corpus callosum. So we'll see that term in black and white here in a few minutes. Okay, but that's going to connect. The reason I'm bringing it up now is, first of all, we've seen it, maybe not known what it was, but it does connect and link the left and right cerebral hemispheres. We do have what are called gyri and sulci. These are the plural forms. One is a gyrus and one is a sulcus. Gyri and sulci. So we're going to notice that the cerebrum has kind of some bumps as well as some grooves in it. So these bumps, okay, are going to be gyri. Okay, so the puffier part, so we come down to the actual brain. So all of these puffy parts, those are gyri, and then the grooves are going to be sulci. Okay, gyri and sulci. And then we also have what are called fissures, and a fissure is going to be oftentimes something that's going to it's basically a deeper sulcus. It's going to be distinctly a distinct fissure or a kind of a crevice within basically there it separates or distinguishes different lobes of the brain. We see the main fissure that we see is this lateral fissure. So the temporal lobes, if we were dissecting the sheep brain, we would see that lateral fissure has a little bit of connective tissue there, but generally that temporal lobe kind of is separate from it's kind of connected. You can almost see how it's connected with the rest of the brain back here, but it's as it swoops anteriorly, it's kind of disconnected a little bit. There's just some connective tissue there that's keeping it together. But that's a fissure. So a sulcus is just it's just a little bit of a groove in between all of these gyri. So we do have a main sulcus, how we can divide the lobes. The lobes of the cerebrum are named for the bones involved. So since you guys know the skeletal bones, as particularly the cranial bones, knowing these different lobes of the cerebrum should be a slam dunk. So we would call this the frontal lobe of the brain. We would call these the parietal lobes. Down here along just above the ears, it'd be the temporal lobes, and then of course back in the posterior area would be the occipital lobes. So I think these are probably pretty straightforward. Okay, now there is a defining feature between the frontal and parietal lobes we call the central sulcus. Okay, and then there's going to be a gyrus right behind it. We call it the post-central gyrus. And then there's going to be one right in front of it called the pre-central gyrus. So those come into play when we're talking about a couple of regions regarding some sensory and motor centers. So you'll see those terms, post-central gyrus and pre-central gyrus, coming up in a little while as well. And then again, we've got frontal, temporal, parietal, occipital. Okay, so a couple of those areas I just mentioned, that post-central gyrus. So right behind, so post meaning behind, central, of course, the center, and then gyrus, it means that we've got a bump. So that post-central gyrus, that's the general somatic sensory. And somatic has to do with what's coming in from the body. So all of those roads that we looked at, all of those pathways that we see are going to generally head into this post-central gyrus. Okay, so this is the area where we store a whole bunch of sensory information that's come from our bodies. It's the somatic sensory area. So, so your general sense of touch. So this is where you might store information of man, if I touch fire, it's going to be really hot. Or if I touch ice, it's going to be really cold. If I touch velvet, it's going to be really soft. If I touch sandpaper, it's going to be rough. A lot of that is stored here. So those terms we give to those sensories that are general somatic senses, that's where this is going to be stored. Okay. The precentral gyrus, so this area, so right in front of that, that's going to be the same thing, just the reverse. That's going to be where we store the motor responses that came from these memories. So as you know, we touch something hot, the motor response that went out is I pull my hand away. And so that memory of the motor response is going to be in that precentral gyrus. Okay, so athletes, when they're talking about muscle memory and repetition, repetitive motion, and not just athletes, right? We're all kind of athletes in certain things because we do repetitive motions. So those repetitive movements are going to be stored in these two areas. So the sensory coming in, this is what I'm seeing, and this is how I'm responding here. So that's where that is located. This transverse gyrus over toward the temporal lobe, that's where we're going to see our auditory, and that makes sense. The ears are here. Why not store a lot of our audio and auditory information in those temporal lobes? And then we go to the occipital lobe, and that's where our visual memories are going to be stored. That's the visual cortex, we call it. Okay, and then consciousness and language. Again, we go back to that reticular activating system that's coming up, ascending, and then kind of dispersing throughout the brain, and then motor and response going out. So two current concepts of the RAS, again, it's what keeps the cerebrum aroused. This doesn't mean sexual arousal. It means awake. Aroused meaning awakened. Okay, so it functions as the alert system or awake system or arousal system for the cerebral cortex. And again, it's what helps us maintain consciousness. And so if we do have, so this again is that reticular activating system, right? So we've got sensory coming in and then distributing that sensory once we get into that diencephalon, that thalamus hypothalamic area. Okay. And language areas, we have what are called the speech centers. These are in the frontal, parietal, and temporal lobes. So kind of this area right in here where they all kind of converge together, that's where we'd find our language and speech areas. So if we do have lesions, MS, for instance, or if we have some sort of cerebral palsy, depending on where it is, if it's in this area, it can affect the ability to speak. And unfortunately, a lot of CP issues tend to come from that area. So a lot of CP patients do have problems with speech. Mhm. Emotions, I mentioned earlier, again, you've got that term limbic. I've said it a few times, but I don't know if we've seen it in black and white yet. Limbic system, again, that's going to be stored in that that diencephalon, that thalamic area with the corpus callosum. I've got a little map of the limbic system here in just a second. You'll find pretty fascinating. The maybe I hope so. The memory, again, we're looking up all the way up at the cerebral cortex, is where we're going to store both short-term and long-term memories. And again, we know with dementia and Alzheimer's, even just age, right? Some of those connections get lost, or some of them get gummed up with plaque, or we get some tangles thrown in there. That's why they say like crossword puzzles and a lot of brain thinky kind of stuff. Crossword puzzles are great because they help with it's all about memory, right? A lot of clues in crossword puzzles relate to maybe older popular culture, just older historical references, geography references. I mean, on it, the list goes on, right? There are a ton of different types of crossword puzzles, but we've really been promoting for years with Alzheimer's prevention. And certainly, if we do have patients who have some kind of Alzheimer's or expressing some behaviors that may seem a little Alzheimer or dementia related, we that the crossword puzzles, again, they can cover a wide variety of kind of stoking the memory and getting different synapses that have maybe been lost, getting them reconnected. So anyway, limbic system, again, we see that that corpus callosum, the thalamus, and then the hypothalamus. So there's an actual pathway of neurons and nerves that travel through this area of the brain. And notice a lot of them start, or one of the main pathways externally is going to be through the olfactory. So we know that that sense of smell has a major effect on the limbic system, on emotions. Okay, a lot of hospitals and clinics have started getting into aromatherapy, knowing the calming effects, the soothing effects, the balancing effects that they can have. Some aromatherapy provides more uplifting effects. Some gives more soothing effects. Some more of just an overall sense of being, invigorated. So there's many levels of what an aromatherapy can do, and this is why we know that it can affect folks' behavior, it can affect memory, and ultimately it can affect their physiology. Because again, we know when folks are caught in a stress loop, sometimes that nature of lavender, or that smell of lavender, or chamomile or something like that, will maybe kind of bring them into more of a calming state. It may trigger even some memories of the past that where they've smelled that before, that put them into that more of a calm state. So anyway, that's kind of fascinating, the pathways of smell and how they affect emotion. There's this little area called the amygdaloid, or the amygdala, and the hippocampus. Again, these are kind of the neuronal pathways of emotion. and some of our emotional memory. Here's that corpus callosum spelled out again in black and white for you. This is that that area that again links the left brain and the right brain together. Okay, so you see the hippocampus and amygdala. These are items you would probably discuss in a psychology class as well. So if you do take psych, I would imagine you'll discuss hippocampus and amygdala in there. Oh, and by the way, olfactory, we've maybe seen that before. I think so. But remember, it means sense of smell. So olfactory. Okay. Ooh, if you're in Burlington, the olfactory smells like chocolate, right? Yummy. Let's see. I'm in Beloit, so the olfactory oftentimes smells like a foundry, which is like iron. And thankfully, I don't live near that. I live further out, away from the smells. But olfactory has to do with smell. All right, so these pathways, we're not concerned about those. I don't know why I even have that up there. Whew, well, we made it through central nervous system. Did you guys, again, there's several items of the brain. Now this Thursday, we're going to do a little bit with visible body. Yeah, you're going to go through, or we're going to go through and look at using visible body, looking at some of these locations that we just went through. So we'll look in visible body on Thursday at the starting with the brain stem, looking at the medulla, pons, midbrain. Then we'll hone in on the cerebellum a little bit, and then zoom in and kind of pull up that diencephalon, that thalamus, hypothalamus, pineal. Okay. So so that's one part of what we're going to do with visible body on Thursday, kind of review a little bit with the central nervous system. And then we're also going to look at some of the spinal nerves and a little bit with the peripheral nervous system. Okay. As we look at the peripheral nervous system, it's the perfect segue from central nervous system, because we distinguish central nervous system as being spinal cord and brain. With the peripheral nervous system, we're just going to look at the nerves that come off of the spinal cord and brain. So we'll start just like we did with central nervous system. We started with the spinal cord. With peripheral nervous system, we'll start with spinal nerves. Okay, so spinal nerves, there are going to be 31 pairs of spinal nerves that are connected to the spinal cord. Okay, so we're going to see 8 cervical nerve pairs. So basically, the first pair of cervical spinal nerves is going to come off between the occipital bone, where the occipital bone ends, and the atlas begins. So between the occipital bone and the atlas, we're going to have our first pair of spinal nerves coming off of there. And then we continue with 7 more pairs. And again, just like our vertebrae, we call them C1 through C7. The 8 cervical nerve pairs we call C1 through C8. Okay, and then we end up at the cervical region. So the first cervical pair, or the first, so we go from cervical to thoracic. So the next group are going to be thoracic, T1 through T12, just like we saw with the vertebrae. Then we're going to have 5 lumbar pairs, 5 sacral pairs, and then 1 coccygeal pair. So 31 pairs of spinal nerves. When we look at the spinal nerves, we've already mentioned this a little bit as we come into the spinal cord. We had the ventral area and the dorsal area. Remember, the dorsal root sensory came in the back, and motor went out the front, right? Dorsal root and ventral root. Okay. So we look at a spinal cord, and we can see again, we've got a dorsal root and a ventral root. So sensory is going to come in, motor is going to go out. Okay? Sensory in the back, motor out the front. Okay. We've got a couple of other items kind of going on here with the peripheral nervous system. As we have these two roots, the dorsal and ventral roots, okay, they kind of can combine a little bit and form what we call a ramus. And this ramus, we have what's called a dorsal ramus and a ventral ramus. These rami are basically going to be the larger extensions. Before you could see the spine, the dorsal ramus and the ventral ramus, they converge and become one. We have what's kind of called like a ganglion. A ganglion is kind of like a bundle of nerve tissue. So in essence, uh, out here, nerves are pretty scattered. But as they kind of converge and head towards their appropriate spot along the spinal cord, we do get in what we call a ganglion. We get kind of the combining together. Okay, so we have the root connected, ventral and dorsal. Then we have the two combined in a ganglion, and then we separate them out again when we get a little bit further from the spinal cord. Okay. We also have what are called chains. Okay. It's along specifically, we have what's called a sympathetic chain, and we haven't really gotten into sympathetic, parasympathetic much. So next week, when we study autonomic nervous system in more detail, we'll kind of refer back to the sympathetic chain. So I really just am kind of introducing it to you at the moment. We see the sympathetic has to do with stress, with kind of speeding everything up, speeding up except digestion. We're going to speed up the heart rate, speed up blood pressure, speed up respiration. So we're going to have an entire chain of a group of sympathetic nerves coming off of the spinal cord that kind of they're centralized to these primary organs that need to be pumped up. Okay, so you'll see this sympathetic chain will come up here shortly in a little more detail. For now, just know that we have dorsal root, ventral root. They combine and form a ganglion, and then from there we can we have our spinal nerve that's either going to have a ventral ramus or a dorsal ramus. So, in other words, we're going to have an aspect that feeds the front of the body, an aspect that feeds the back of the body. Now, as these spinal nerves come off of the spinal cord, we do have a few areas where they're going to kind of bundle together and form what's called a plexus. So the first group of spinal nerves that kind of, in essence, kind of feed the same area is called the cervical plexus. And the cervical plexus is located, you guessed it, in the cervical region of the vertebral column. And primarily, though, it's going to be those upper cervical. We're generally going to see the first four pairs of spinal nerves converging and forming what we call a cervical plexus. Okay, so I'll pull an illustration of that up in just a second. Brachial, we know, means arm. The brachial plexus is going to come off of the lower cervical spinal nerve. So we're going to see C5 to about T1 of our spinal nerves kind of coming together and feeding the arms or the brachium. So let's take a look at these so you kind of get an idea of what the heck it is we're talking about. So we see the spinal cord and these first four spinal nerves coming off, they kind of bundle together out here. We call it the cervical plexus. And this cervical plexus is going to contain nerves that basically just feed items in this area. So the upper neck region. So what muscles are in the upper neck area? We have the trapezius, for instance, one of the major muscle groups of the upper neck and shoulders. So a lot of these, the motor and sensory aspects of the skin of the neck and of the musculature of the neck is going to be related to these first four cervical nerve pairs. Okay, so we see the trapezius muscle, supraclavicular, so somewhere above the clavicles. Okay, there's one more. There's an oddball in here. Well, some of these you may find. Here's sternocleidomastoid, right? Another muscle of that area. So we see sternocleidomastoid, trapezius. It makes sense. The musculature in this area are going to be connected to nerves that come off of the spinal cord in that same area. All right. So there is one, though, this one down here called the phrenic nerve. Phrenic nerve right down here at the bottom. Phrenic has to do with the diaphragm. So you can see if we follow that up, phrenic nerve or down, we can see C3, C4, and a little bit of C5, all feeding and leading to being the phrenic nerve. So again, the first cervical nerve pair, this is going to be the occipital bone here. This would be the first cervical vertebra here. Second cervical vertebra, third cervical vertebra, fourth cervical vertebra. So if we have damage to the third or fourth cervical vertebra, that could lead to some issues with respiration. The diaphragm functions to kind of flatten out and expand the volume of the lungs. So then air will rush in from outside to the inside. Okay. And the phrenic nerve enables the diaphragm to flatten out. So if we've got damage up here, it could affect nerve flow to the phrenic nerve, or from the spinal cord to the phrenic nerve all the way down to the diaphragm. So this is one that does travel. Most of these nerves generally are going to feed items that are close by. Phrenic nerve does travel down to the diaphragm. Again, also why neck injuries in the cervical area, we're very concerned about the ability to breathe for the person, for the patient. All right, so that's your cervical plexus. Now, when we look at the brachial plexus, we come down a little further and look at the spinal nerves coming off of the lower cervical area and even that first kind of thoracic pair of spinal nerves. So, but generally we would think of the lower cervix. So the first four cervical pairs are going to be the cervical plexus. The next four cervical nerve pairs are going to be the brachial plexus. And what that means generally is that we're going to be sending all of the nerves out to the arms that come from the neck. So your arms and all the way out to the hands and your fingertips, the sensory that you feel here, and then the motor that allows you to do this, that is coming from the lower cervical region. So if I have damage to the lower cervical region of the neck, that's going to potentially cause issues all the way down to the fingertips, into the hands, into the wrists, into the forearms, and so on. So this is a long pathway. These are long nerves. Okay, so there's a lot of musculature as well, right? We've got trapezius here. We've got the deltoid, pectoralis. We've got biceps, triceps, brachialis. We saw all of those forearm muscles. Hey, there's a lot going on. We see the clavicle, scapula, ribs. Man, and then all of the musculature around there. Okay, so if we have any type of impingement or inflammation anywhere between C4 down to C8 all the way out to here to the fingertips, it could affect the functionality motor wise. It could also affect your ability for the sensory aspects to come into play. So again, when we have patients who have fingers, hands, wrists, elbows, shoulder issues, we're certainly going to be looking at those areas, but we also want to remember that the nerves that feed those areas are coming from the lower cervical vertebrae. Okay, so the lower cervical vertebrae have nerves coming off of the spinal cord, bundling together, called the brachial plexus. Okay. Hyperextension of an elbow, of a shoulder, a dislocation of the shoulder can all potentially create damage distally to the injury. And we have three major nerves that supply the forearm and wrist and hands, and they're generally named for the bones that are near them. So we're going to have what's called the funny bone is actually the ulnar nerve. So on the ulna, you have the ulnar nerve. Laterally, we have the radial nerve. And then in between is called the median nerve. So when we look at what nerves feed the hand, we look at the palm of the hand and we can see the ulnar nerve. Okay, the ulnar nerve is going to play a pretty big role. Okay, and then the median nerve. Radial nerve doesn't do much with the palm of the hand sensation. Now, back of the hand sensation, you're going to have the radial nerve playing a major role, and then the ulnar nerve. Now, notice median nerve is feeding the fingertips, thumb tips. Median nerve is your carpal tunnel syndrome nerve. So oftentimes we've got an issue here causing swelling. Could be from repetitive use, but there'll be some inflammation in this area, impinging and impeding the flow out to the fingertips. So we could have sensory issues as sensory's traveling. So there might be some tingling going on that's affecting the sensation. There could be motor problems. Maybe the patient has problems making a fist. If a patient has issues making a fist, that could also be related to carpal tunnel syndrome. Now, again, is the problem here with the median nerve? It's possible, absolutely. And in fact, a lot of the surgical procedures that are done focus on this area to relieve and alleviate some of the pressure that's being put on the median nerve. Okay. But we're finding that if we travel up, we could have some issues all the way up here in the shoulder. We could have some inflammation. There's a lot of lymph nodes in this area, so there could be, as well as musculature, ligaments from the shoulder joint. So we could have damage or an injury. We could just have repetitive use, things from being in this position over and over, like whatever it might be, mechanics or plumbers, or maybe somebody's in this position over and over and over where they're having to do something. But what that does is causes inflammation to build up in the soft tissue, and that can affect the flow of electricity down to here to get the muscles to function. It could also affect and impede the pathway and delivery of sensory. It's like putting a little roadblock in here and then expecting the signal of motor to get from up here all the way out to here without any issues. It's like expecting, the sensory from out here to travel past that roadblock and get up here. And we've got a clear path and clear knowledge of the sensation. We've got a clear path and clear ability to create a motor movement. If we put a little block or impingement to scar tissue, whatever it might be, in any of these areas along this pathway, then we would see a potential decrease in sensory, or at least compromised sensory, and certainly then a decrease in motor function. So a problem here, my point is not always due to problem in the soft tissue here. Problem here sometimes is due to soft tissue problem here. Sometimes due to soft tissue problem up here. Sometimes due to soft tissue problem all the way up in the neck. Believe it or not. Yes, we have patients have come in all the time, and they have numbness, tingling, motor issues all the way down in their forearm, wrist, and hands. we come up, we look at this and in their posture, they've got muscle tension. They have no range of motion. They can't move their head or neck from side to side. So we run them through ranges of motion. They maybe can get to here and here. They can maybe do this and this. Maybe get, we need good range of motion. So then what we start doing is, if we have limited range of motion, limited sensation, limited motor, then we've got to address that up here in the neck and shoulders to then elicit better flow out down here. So anyway, that's about it for cervical and brachial plexus. We do not have a thoracic plexus. All of the thoracic spinal nerves are just going to feed regions around the thorax. We do have a lumbar plexus that's going to be coming out between L1 and L4, and then a sacral plexus a little bit lower. And then we even have a little coccygeal plexus as well. So let's take a look at, we typically combine the lumbar and sacral plexuses into what we call the lumbosacral plexus. So one of the main nerves that we would see is this one here, the sciatic nerve. So that's really the key features for lumbosacral plexus. Just like we saw with the brachial plexus feeding the arms, lumbosacral plexus is going to feed the hips and the legs. So again, if I have knee issues, hip issues, ankle, whatever, toe issues, yeah, we definitely analyze and assess those areas, but we also are analyzing and assessing what's going on in the low back, the lumbar region, where the lumbar meets the sacrum. That's where the sciatic nerve comes off. This is where, again, we see a lot of patients with a lot of issues, with low back pain, hip pain, leg pain. Again, this is part of why we see that, why someone with low back pain would have numbness or tingling or pain all the way down in their calf, or all the way down in their ankles, or in their quads, or the back of their hamstrings. Okay, so if we've got some disc degeneration, or we've got some musculoskeletal issues up in the lumbar area, we certainly could expect to have some issues heading all the way down, maybe to the tips of the toes. We can see that sciatic nerve traveling posterior, going through that sciatic notch of the ilium. We saw the ilium posteriorly, again, has that big notch or groove. That's where the sciatic travels. You can see it goes all the way down and into the heel or calcaneal area, and even wraps a little bit under the sole of the foot. So if patients who have, sometimes they'll come in, they'll have actual muscle twitching in the calf muscle. Their calf is in like this constant state of twitching, or maybe they'll get cramps in their calf muscle, or cramps in their hamstrings. Again, that could be an indicator of something going on all the way up in the lumbosacral area, and some of the musculature in the gluteal region and hip region could be inflamed, and some of the inflammation of that musculature can lead to flow problems and impinging on the flow of electricity out or back to the spinal cord. So we can see that lumbosacral plexus. Again, we can look at, is it, where does the patient have sensation issues? Is it the whole bottom of the foot? Then it could be the tibial nerve. So then we find the tibial nerve. And we can see the tibial nerve is right back here, right behind the knee, kind of buried, makes a little bit of an appearance, but generally stays posterior. And again, look where it goes, right up as part of that sciatic. So tibial nerve is a branch of the sciatic nerve. So again, if patients express some heel issues, they've got some tingling in the heel, We even have right down to some excessively dry skin down in the heel area. Very inflexible when it comes to dorsiflexion and plantar flexion. And then we come down and it's either no sensation or hypersensation the bottom of the foot. Man, we're almost sure that we either have something wrong with the calves and the knees, or we usually bring it all the way back up to sciatic issues. Okay, so those are your spinal nerves. So remember, spinal nerves, just a couple of tidbits: 31 pairs of spinal nerves. We have this 8 cervical, and then the rest fall in line with the numbers of vertebrae. So 12 thoracic, 5 lumbar, 5 sacral, and then 1 coccygeal pair. We can bundle these spinal nerves into plexuses. So we had cervical plexus and brachial plexus coming off of those first 8 cervical nerve pairs. Cervical plexus generally just feeding kind of the throat and neck area, maybe a little bit with the face and the upper neck. The brachial plexus coming all the way out and feeding to the tips of the fingers. Then we had the lumbosacral plexus, including that sciatic nerve, kind of feeding the legs and the hips, especially the lower back or the posterior aspects of the lower appendages. Okay. Now, nerves, by the way, too, are generally named for the bones or the regions that they're in or near. So we did see a couple of exceptions, right? Sciatic, but that's one everybody's heard of that, and we all know that that's low back down to the backs of the legs. Next up, and then we'll kind of leave off with we're going to go through some cranial nerves, and we'll leave off here with peripheral nervous system. And then Thursday we'll look at visible body, kind of break down some of the central features. And then we'll come break down some of the aspects of the peripheral nervous system, especially these cranial nerves. So as we segue into cranial nerves, we have 12 pairs of cranial nerves. Again, we've kind of talked about them a little bit. We've seen them a little bit. We had a little kind of a teaser trailer with the brainstem, the pons area had quite a few. Even the medulla had some little kind of sprigs coming off of it. But these are going to be cranial nerve pairs. We have 12 pairs, mostly connected to the undersurface of that brainstem. We have what are called mixed cranial nerves, sensory cranial nerves, and motor cranial nerves. We're going to see special sensory as well. Everything we've done up to this point has pretty much been sensory coming in, motor going out. And when we say sensory, it's generally been the sense of touch. So now we're going to have sense of touch nerves, but we're also going to have special sensory nerves for smell, sound, vision, those types of things. All right. So we look at the map for the cranial nerves. Now, do you guys need to know all 12 of these pairs? Probably not, but I think it would be a good idea to know a couple of things. First of all, that we do have 12 pairs. They are numbered using what are called Roman numerals, and we also abbreviate them with the letters CN, meaning cranial nerve, and then whatever the Roman numeral for the pair is. Oftentimes the name of the nerve will tell us a little bit of information about it. So Thursday, you're going to do a little bit more with what the function is of each of these cranial nerves. And I'm going to tell you the basics now, and then we'll go back through it a little bit more on Thursday. So we start with olfactory. We know, again, that olfactory has to do with smell. So the first cranial nerve pair is the olfactory nerve pair. There are several mnemonic devices for remembering the cranial nerve order. So the first one we have is O. The first 3 are all 3 O's. Okay. So 3 O's started off. Olfactory, optic is number 2, and then oculomotor. Okay. Olfactory has sense of smell. Optic is going to help with vision. Okay, so notice too, our nerves have different color codings. Blue are going to be sensory. So again, blue, olfactory is sense of smell. Optic is sense of vision. Notice too that optic nerve, as it comes in, we go through that optic chiasm. We see the pituitary here, and then we end up traveling to the opposite side of the brain into the occipital region. And then number 3 is oculomotor. So notice this next batch, we're going to see 3 pink, which are going to be indicative of motor aspects. So the eyeballs have what are called extrinsic muscles, meaning muscles outside of the ball itself. They're going to allow our eyeballs to move in pretty much all directions. So these are going to be what we call extrinsic eye muscle nerves. So oculo, meaning something to do with the eyeball, and then motor means movement. So the name of the nerve tells us a lot about it. Oculomotor moves the eye. That's number 3. And then trochlear is number 4. That's extrinsic eye muscles. And then I'm going to come down here. Number 5 is actually trigeminal. That's going to have both motor. That's a mixed. That's going to have sensory and motor. We'll come back to that one in just a second. I want to go back up to the eye movers. Abducens is number 6. Okay. 3 old teachers tried for trigeminal aerobics. Okay, so 3 old, meaning there's 3 O's, 3 O's, 3 old teachers, O, tried, 3 old teachers tried aerobics. And then number 7 for facial, F, for very good vibrations around their heart. Okay, so 3 old teachers tried aerobics for very good vibrations around the heart. So the first letters of all, that's a lot, right? That's a mouthful. So then anyway, trigeminal. So we'll come back to that in just a second. Trigeminal, cranial nerve 5. Okay, cranial nerve 5 is mixed. We're going to have sensory of the skin, basically on the entire face. Okay, so the bulk of the face, sensory, is going to be trigeminal. And then we also have the motor aspects, primarily the motor aspects that kind of keep the proprioceptive tone of the muscles of the face going. So if we have trigeminal neuralgia, that can lead to then sensory issues potentially, as well as the proprioceptive tone of the face. So you may have like a droopy or saggy face with trigeminal neuralgia. Okay, so 3 O's. Teachers tried aerobics for facial nerve, number 7, just like it sounds. It kind of works a little bit more with maybe the front of the face. So we look at some of the forehead, orbicularis oculi, orbicularis oris, maybe some of the pucker muscles like the buccinator. Okay, so we would see the facial nerve primarily dealing with facial muscles, whereas trigeminal deals more with maybe the side of the face, the cheeks area. 3 old teachers tried aerobics for, and then we're on to the V, very vestibulocochlear. That one we break into 2 sections. We have what's called the vestibular aspect, and then the cochlear aspect. Vestibular has to do with balance and equilibrium. cochlear has to do with the sense of hearing. So both of these, so vestibulocochlear notice is blue for sensory. So that has to do with the sense of sound as well as the sense of balance and equilibrium. Okay, so three old teachers tried aerobics for very good glossopharyngeal. Glosso means tongue. Okay, glosso means tongue. Pharyngeal means the pharynx. So we're going to have mixed motor and sensory dealing with something with the tongue. So this would probably have to do with chewing, speaking, swallowing. Okay, glossopharyngeal. Very good vibrations. Here's probably one of the most well-known of the cranial nerves. It's also the only cranial nerve that leaves the cranium to any degree, and it's called the vagus nerve. So CNX, that's a mixed nerve, mixed cranial nerve, vagus, VAGUS, not VEGAS, VAGUS, vagus. Vegas is a word that means wander or wanderer. So this nerve wanders out of the cranium and heads down into the thoracic and abdominal pelvic areas. So we see the vagus is the wander. This is a big nerve when it comes to some of the parasympathetic or most basic homeostatic rhythms established with heart rate, respiration rate, digestion. Okay, so vagus nerve does a lot. We'll see it next week when we get into autonomic nervous system and fight it, right? Sympathetic, parasympathetic. We'll talk about the vagus nerve quite a bit next week. It's probably the one of all of these nerves, of all 12 pairs, this is the one you definitely need to etch into your long-term memory. CNX, or cranial nerve 10, is the vagus nerve. It wanders, it travels, it feeds the heart, it feeds the stomach, it feeds the lungs, it feeds all kinds of places. So no vagus nerve. If nothing else out of these 12 pairs, if you can remember that one, you're doing good. You're doing great. If you can remember, olfactory means smell, optic means vision, oculomotor means moving of the eyeballs. Trigeminal has to do with facial, not facial, more or less the lateral aspects of the face. Okay? Sensory, really, of the whole face, but some of the muscular movements of the cheeks, whereas the facial nerve does more of the centralized facial movements. Vestibulocochlear, when we do the sense of smell and sense of balance next week, we'll talk about that one again. Glosso has the word for tongue in it. Pharyngeal has the word for pharynx in it, which is kind of the back of the throat area. So the names tell us a lot about these, I guess is my point. We do have two more very good vibrations around the heart. So accessory cranial nerve 11. It's just going to be a motor that's going to help with sternocleidomastoid, trapezius, some of these upper neck muscles. So accessory is really the accessory to the cervical plexus of the cervical spinal nerves. So remember, we have the cervical plexus, cervical spinal nerves. Okay. So this is the accessory of to those. Okay, so that's why it's called that. It accessorizes some of those neck muscles. And then lastly, the 12th pair we call hypoglossal. So we see glosso again. Glosso again, glosso means tongue. So hypoglossal means under or below the tongue. Okay. So the name of the nerve tells us a lot about it. And sure enough, it does a lot of the motor aspects of your tongue. So hypoglossal does a lot with chewing as well as speech. So basically, all the stuff that's going on in the head and in the face and is going to be controlled and dictated and connected with the central nervous system via these cranial nerves. I think I am going to conclude. We're going to leave it at that. You've gotten plenty of information today. We've made it through the central nervous system. We've really made it through the peripheral nervous system. So on Thursday, that's gonna in essence be kind of a lab day. I want to go through some of the basics again, but with visible body of the central nervous system, reviewing those key features. Then we'll go through the peripheral nervous system, review those key features, and call it a day. And then on Thursday, and then next week on Tuesday, we're going to finish up with autonomic nervous system, and special senses a little bit. Next Tuesday's election day. Woohoo! Finally. And then so seems like a good seems like a good day to talk about sympathetic and parasympathetic. So every day is a good day to talk about that stuff. But anyway, next Tuesday we'll get into autonomic a little bit, and then next Thursday we'll conclude this unit. We'll talk a little bit about special senses, and then we'll start in on cardiovascular and do that for a few weeks, and then we'll get into eating and breathing and peeing and birds and bees to finish off the semester. So anyway, you guys are cruising. We're cruising at a good clip. I'm going to leave it at that. I'm going to stop the recording. And again, if you guys